So the management of cesarean scar pregnancy is medical. It is systemic methotrexate therapy. Surgically assisted medical management, local methotrexate with sac aspiration and uterine artery embolization. Surgical management, DNC, hysteroscopic resection, laparoscopic excision with repair, open excision and repair, combined laparoscopic and hysteroscopy, hysterectomy, combination of uterine artery embolization followed by surgical resection, methotrexate followed by interval resection. Cervical pregnancy is 1% of all the ectopic. I've had a pregnancy in IVF with cervical pregnancy. We did a curettage and it was done. Chronic endometritis in cases of uterine curettage and in cases of IUCD, this can happen. So, it's an empty gestational, empty uterine sac, G-sac below the level of internal os, absent sliding sign and a barrel-shaped cervix. So, the clinical diagnosis is uterine bleeding without cramping, soft enlarged cervix equal to the fundus. POC is firmly enlarged attached to the endocervix, closed internal cervical os and partially open external os. Ovarian pregnancy is 1 to 3% of the pregnancies. Clinical features is mimics tubal ectopic, wide echogenic ring with internal anechoic area. The Spielberg criteria is the criteria for ovarian pregnancies. Fallopian side of the affected side is intact, no connection between tube and gestation. Fetal sac in normal position, ovarian tissue in sac wall. Gestational sac may be connected to the uterus by ovarian ligament. So, the treatment of choice is laparoscopy or laparotomy, removal of the G-sac, enucleation and wedge resection, oophorectomy if excessive bleeding. Abdominal pregnancy can happen in 1% of the pregnancies, primary or secondary. Implantation of the conceptus into the intraperitoneal organ and reimplantation after conceptus is expelled from the tube. So, the abdominal pregnancy is hemodynamically unstable, hemoperitoneum or shock, hemodynamically stable, persistent abdominal pain, painful fetal movements and abdominal presentation. Ultrasound criteria, absent intrauterine gestational sac, absent tubes and complex adnexal mass, gestational cavity surrounded by loops of bowel. MRI, you can have a hemodynamically stable, MRI is another important diagnostic modality. You have to see the placenta, see the feeding arteries and detect placental adherence. Treatment is, it's a team approach. You cannot handle an abdominal pregnancy only with a gynecologist. You need a GI surgeon also or a good surgeon. So, it should be done usually by a laparotomy. Early pregnancy alone can be done by laparoscopy. So, placenta it's usually left inside because too many vessels will be there in the mesentery and all. And then complications are septic peritonitis, ileus, bowel resection and hemorrhage. So, these are some of the case reports. Okay. Heterotopic pregnancy, it's simultaneous presence of intrauterine as well as ectopic pregnancy. Incidence is 1 in 10,000 to 1 in 30,000. 71% of the patient with heterotopic pregnancy, one of the predisposing risk factors is present, okay, and TVS is preferred over TAS. The treatment of choice is laparoscopy, selective embryo aspiration, the surgically assisted medical management KCL or systemic methotrexate is contraindicated.